This time every Tuesday is when we feature our friends from GRMC on Your Healthcare Partners, brought to you by GRMC, where patients are partners. And welcome into the studio some fine ladies from GRMC, and this is in the Department of Patient Education, right?
Yes.
So Dr. Melliza Young, nice to meet you. Janice Baldonado, nice to meet you as well. And Taijeron, how are you? Thank you, ladies, for coming. Go ahead. I'm hoping that you'll just speak right into the microphone. Okay. And perhaps you could tell me, first of all, they have an entire patient education effort that's dedicated to informing patients about their conditions and everything else at GRMC. Yes. We'll start with you, Dr. Young.
So the Patient Education Department is really a unique program or service that we provide at our hospital. And this really aligns with our philosophy of care, which is the patient partnership. So remember, our slogan is where patients are partners. Mm-hmm. So with patient education, we serve as a support to the entire healthcare team in providing patients the right information and the guidance on how they will continue to manage their care when they go home. And so really having all these services available to them, a resource center that's open during business hours, and also for us being available over the phone just when they need any type of health information to support their care is what we do provide.
Isn't that just really that takes all the mystery out of it? I mean, it's one thing to have a medical issue, but it's another thing to not know anything about it. Do you find that with the patients that you advise or counsel or talk to, that once they start getting the information, they start to feel a little more relaxed?
Definitely.
About what the next course is, mm-hmm. Right?
Yeah.
So, you're more than welcome to expound at any point. Dr. Mila, what's your specialty? What's exactly you specifically?
So I have a medical background from the Philippines, and so I'm a general practitioner, although I don't practice medicine here on Guam. Mm-hmm. But it's this medical background that allowed me to reach out and connect to patients in a way of being a source of their health information and putting all these reliable resources together and providing it to them. And it's not just what they see on paper, what they see on print, what they see on videos, but it's the face-to-face encounter and having that personal advice that we offer to our patients when we see them in their room or mm-hmm. when we see them in our resource center.
Okay. And under what circumstances are you involved in the process of patient care? Do they call you from the beginning? Is it something voluntary that the patient asks for, or is it all part of the treatment?
What usually happens is we receive education orders from either nurses and physicians, and we have a process where we come in the morning and we gather all the education orders that were requested. For example, if it's tobacco cessation, congestive heart failure management, and we organize our paperwork. We gather the information that's needed for that teaching, mm-hmm. education, and then we proceed to visit the patients and inform them that there was a referral to conduct teaching on, for example, tobacco cessation or congestive heart failure or diabetes management. And then they agree with the teaching, they receive our educational material, then we continue with the education and maybe ways to help them live their healthy lifestyle in hopes to decrease their complications to their current health condition.
Okay. Knowledge is power, in other words. Erica, I'm noticing in your career bio that your specialty is in healthy habits and lifestyle and that sort of thing, right? And sometimes it sounds like you come in kind of after the fact. You can come in after the fact, after a person is, for example, diagnosed with diabetes. You might come in after the fact about healthy choices and lifestyle. But at that point, do you get the feeling that the patient's like, yeah, I wish I knew this about 5 years ago?
Yes, a lot of times it's
It's just helping them to, they do know it, and it's just kind of, we're there to kind of reinforce and let them know that they're still there. So we also do follow-up calls with them, so not just the patients who are in the hospital, but so when they are discharged, they can always call us, and if they have any questions, maybe they needed more information on maybe how to cope with so I do a lot of tobacco cessation. So a lot of them, they know that that it's best for their health not to be smoking. So what we do is we try to help them cope with ways to help them. So like if they're going through any withdrawal symptoms, or if they'd like any other information, and to refer them to any other resources.
Let's get to the meat of that, because all of you are involved in some form or fashion in tobacco intervention, right? So this is one of those things. The community outreach on the dangers of smoking is there. There's warnings on the packages. Kids are taught in schools. There's signs on the wall. I mean, there's a host of available information out about the dangers of smoking, and when we talk about, like, for example, they have that, what is the No Smoking Day in November? American Smokeout, the Great American Smokeout. What we're encouraging, Americans to do is quit smoking for the day and, see how that affects your body. We all know that after a day of smoking is really not the battle. After a day of smoking is after a day of smoking. I mean, anybody who smokes knows that it really doesn't have much of an impact. It's the stuff that happens afterwards. Can we get into the meat of that? First of all, the person has to come to you. Do they come to you in a form of a patient, or they come to you on a voluntarily basis that they want to quit smoking and they just need to know how?
Yeah, actually both ways. And so if they're admitted in the hospital, that's a given, because they're there, they already have the complications from smoking. But when we do the outreach, that is when we help them to realize that this is something that they would need, that we don't want them to reach that point of, being in a hospital bed and having already these different, chronic conditions and also affecting, the lives of other people, being exposed to secondhand smoking. And we also have some patients or some clients, I would say, that they come in just to get information, and we are always here for them, waiting for the time that they will be ready to quit. Because once they're ready, they, no matter what kind of information you give them, and all these guidance that we provide, if they're not ready to quit, then it doesn't make sense for them. Like, they won't even give an effort to.
They have to want to do it,
right?
And that's part of the problem is to get them, lead them to, make them drink the water, I guess is the other point. The other conversation that I wanted to have with you is about just basic communication. Dr. Felix Cabrera was here last week, and I admire him because not only is he's a young local doctor, but he's really sort of trying to find the balance between, being a human with a very strong sense of Christian values and spiritual values, and then being a physician, which can be very, anesthetic. There's no emotion. Sometimes you feel when you're talking to a doctor, it's just reading out of the, medical book. But in your positions, you really do have to bring it down a whole lot to get to a level. Because first of all, I'm only assuming that a lot of the patients that come through don't have any idea what the official terminology is to describe their condition. Do you find it difficult to bring it back a little bit, or to bring it home to a level they understand?
So in terms of, along that line of how we communicate to patients in our capacity as patient educators, this is where we focus on our health literacy initiative. So last month we just celebrated, Health Literacy Month. This is where all of the healthcare providers in the nation celebrate health literacy, which is an individual's capacity to obtain, process, and understand health information. So when we talk about health literacy. So we try to put it into like different concepts. So the process of obtaining information is when we provide them these different health educational materials. And are these educational materials on the level that they understand? Is it on the language that they understand?
Yeah.
So if it's not on the language that they understand, then our hospital provides a translation and interpreter.
That's interesting. Yeah.
Yes,
Yeah.
that would would again help the patient to understand all these things happening to them, and at the same time for our healthcare providers to be able to get as much information that they will need to address the patient's care. And so that's the obtained part. So the process and the understanding the health information all boils down to the patient itself. And this is where we come in terms of learning more about the patients, like who are they, who they are,
personalizing,
what motivates them, what inspires them,
right.
what is valuable to them.
Yeah.
And again, that is all. So all these information and these communication skills that we take in or we give into patient will really all depend on, is the patient ready for these kinds of information.
It must be tough for them. I mean, especially because we have such a diverse culture. We have diverse cultures here, so just basic communication, in English, I think is probably the best way to put it. You're finding people who speak different languages that come from different countries and different island cultures. So is that a challenge for you too? Because you have to explain some of these really specific medical terms and trying to bring it back to somebody who is not speaking English as a first language, or the elderly who have a really hard time understanding, for that matter.
In some way it is, but with the technology and all the different means to help patients understand, so we have our own tiny whiteboards that we can just draw, how to take it in, or like how, what is the effect or something. And we also have videos, and again, it's the follow through that's important, because even if we provide them the education now, we always ask them, how do they find these information valuable to them, or is it something that they found understandable? And then we always offer that our availability for them to follow up if there's any other new information that needs clarification. And again, we're always open for that.
Yeah, and the conversation, speaking with the elderly, sometimes you have the elderly that come, they don't necessarily have any support system. Their families are not interested, or they are not available, or something. They drive themselves, or they try to get to these appointments, and they are trying to deal with this by themselves. That must be a challenge, especially coming from Guam. It's hard to... Did you want to address that one?
Well, we do have patients that during our teaching in their hospital room, they voice their concerns of, for example, not getting the necessary care that they need because of transportation issues. They don't have the support system to help them in managing their health conditions. So we also try to play a role as in trying to advise them with the information that we can provide, basically to help them to try and get to where they need to be. We try to address that. We try to sometimes we get personal, meaning we try to advise them our own opinions and maybe our own suggestions to help them basically and to follow through on their management. So we've had many patients that actually voice their concerns. So, for example, one says the transportation issue with the public transportation. They don't come on time. They don't arrive on time. So she's unable to get the hemodialysis that she needs on time. So, we try to offer suggestions. Maybe you can have someone wait at the station for you or whatnot. And those things we do hear a lot, and from different patients and their families as well.
Yeah.
And it's kind of difficult, but then that's where we as a patient partnership, we voice the concerns to social work. So we involved everyone in the team in the hospital. So there's social work. We voice the concerns to the nurse as well, the doctors. That way we can try to find ways to assist this patient in every way possible to basically get better.
That must be really frustrating. But you also, it seems to me, in this line of work, you have no option or choice than sometimes to become emotionally involved. Did I hit a nerve here?
Yes.
I mean, how do you not know something about somebody, personalize, this communication, and then not care?
Exactly.
Yeah.
We also get a lot of patients where they feel really comfortable with telling us, because
More than just what you are asking.
And
Yeah.
that
Yeah.
really, it helps us understand where the root problem is and why they're not getting the care that they need.
Yeah.
And so then that's where we can assist them and help them understand and help them work from there.
But you guys aren't playing social workers either, and that's what I'm saying. You're limited in the capacity, so you may get to the root of somebody's issue, and they may see it, but you don't necessarily have the authority to, or do you direct them to services or that sort of thing?
Yes. So understanding our limitations also as patient educators. So this is when the collaborative effort comes in. So we refer them to the social worker and advise them about the patient's needs, and of course, like what Janice mentioned, same thing with the nurses, with the doctors. So it then becomes a team effort. And so our role is again getting all these information of what will help the patient address their needs or help them in their care. And if it's not reflected, say, in the notes and what we see from the electronic health record, and we're able to provide that in knowing that that information will be valuable to the patient's care, then it's our role then to impart that to the rest of the member of the community.
How does that work in the delivery of care? And when the doctors necessarily see some of these stories and some of the emotion that's surrounded, does that translate? Obviously, it would translate to better care, but is something that they're also aware of in the whole process of educating the patient?
Yes, and in fact, we have a discharge planning team. So like twice a week we meet with the doctors and the different members of the interdisciplinary team, and we talk about all these issues that would help and that will speed up the patient's care in the hospital and also help them transition to home or to wherever their needs will be met once they leave the hospital.
Okay, so the doctors are learning something from you too. Well, that works all the way around. Is there anything that you see in this part of medical care in the future that can be expanded, perhaps, or that you see as unique to Guam that can be addressed that in the course of patient education?
Definitely, because like what I mentioned earlier about health literacy, so there's been a lot of studies going on how to use that. So health literacy in itself, it's used as a public health strategy to health promotion, and it's also considered like a risk factor to clinical care. Like if patients have limited or low health literacy, they may not be able to understand the care that they need. And so using that health literacy to collaborate with different levels of care. So it's not just in the hospital, but also collaborating with, say, the public health sector and other private sectors to really make sure that the patient understands on how to navigate our healthcare system and that is culturally acceptable to them. And again, that is something that is collaborative. And really, it's not just the effort of the hospital, it will be an effort of the entire community.
It must be difficult after the patient has been discharged. You kind of keep your fingers crossed that everything that they learned that can be applied, and all of the obstacles that stood in the way of them continuing, with this kind of care have been removed, right? Because it's not like you could call them up on 8 o'clock on a Sunday night and go, well, how's it going? Or do you?
Actually, we do.
Oh, good for you.
The care continues. The care continues after they've been discharged. But first, we would have to request for their approval. So we, after the teaching, we ask them if they can, if it's okay, if they can provide a contact number, which we can call them at, to check on their status, to see how they're doing, if they need any more resources to help them better their management at home. So they do, and we have a list of patients that we normally call, be it tobacco cessation or congestive heart failure management, diabetes management, and we call them and basically say, how are you doing? Are you taking your meds on time? You have any questions, concerns? Is there anything that you need more clarification or help on that we can assist? And again, we advise them, we're here for you. Give us a call, or you can stop by our office, pick up more educational material if needed. So the care continues afterwards, after they've been discharged. And especially for those who who provide the follow-up calls, who actually agree to the follow-up
Only
calls.
for those who agree.
I'd like
Agree,
to
yeah.
add, we also try to include the family, so like the
Yes.
caretakers, because like especially for tobacco cessation.
Oh, yeah, that's
for
hard.
them to try to quit,
Yeah.
we try to get a support group, and that would be their family.
You don't get the 911 call, Erica. It's like, oh, I'm standing in front of this place that serves burgers. Talk me away from the drive-through.
We do actually. So we did-
Do you really?
Well, the tobacco cessation. So we just finished our. We also offer tobacco cessation classes, and then so we just had one participant, and so she calls us up weekly and tells us like, hey,
These are the
this-
challenges.
Yeah, and these are challenges, and this week I didn't smoke, and so
Yeah.
and we asked her, okay, so what, where else? So we congratulate her, and we're a support group for her.
It's
If she
the
doesn't have a
triggers. I mean,
support group at
sometimes
home.
it's the
Yeah.
triggers, right? I mean, I don't. Did you ever smoke cigarettes? A doctor? Janice, come on now.
No, ma'am.
14
Coffee.
years old in the
That's-
bathroom at the school?
that's
No, Erica.
That's my addiction.
You're not hiding in your mom's closet. Okay, just making sure we're all coming clean here. I was a smoker for a very long time. I mean, I started smoking when I was a teenager, and would stop smoking every time I found out that I was having a baby. And then weirdly would pick it up after the kid turned like 3. I don't know what it was, and I don't know how it stopped. But the last child, I said, well, this is going to be the last one. I'm going to quit. And if I quit, it's going to be forever. So it was easy to quit smoking because it was disgusting. I mean, clearly when you're pregnant, it's one thing. But then the smells and all that stuff just after a while. So once I quit, I was done. But every once in a while, I'm really full, and I don't want to smoke. I mean, I think it would kill me if I took a drag of a cigarette. I think it would honestly put me into cardiac arrest. But there are some times where after I see people dragging on a cigarette, or they're in a bar, I'm like, oh my God, I remember how incredible that feeling was. So you always have it. You know what I mean? Not that I'm telling you something you don't know, but I mean, you always have the trigger. Whether or not you actually commit to it is a different thing, and that's the hardest part. So how long does it take after you quit smoking where you're more immune to these sorts of triggers and I want their habits, really, and you almost have to get rid of the habit in order to stop the trigger?
Right.
Okay.
So if you've been smoking less than 5 years, it would take about 6 to 12 months for that craving to go away. So if you're smoking for 5 years and above, the craving will still be there for at least about 18 months. So like what we mention always in our class, that for the smoker is to be cautious or be cognizant about the 6-month time from the time they quit, that they already feel confident of not falling into smoking again or to relapsing. But it's the science. There's science behind it. I mean, I didn't just come up with the numbers.
Sure.
And but yes, it's at least 18 months if you've been smoking.
And I mean, a lot of it is socialization, and it's not like you can stop, going out to a restaurant and watching all your other relatives outside at brunch smoking out by the pool. You know what I mean?
Yes.
But it's not like you can stop all those activities. You just have to find a different distraction.
Definitely.
Get a glass of wine. I don't know what's the distraction. Vaping.
So in our
No, huh?
teachings,
Oh.
we do offer certain positive ways to combat those types of distractions, or what we call triggers.
Okay.
And you mentioned earlier that when you go to a bar and you see people smoking, it makes you think like, oh gosh, I used to do that, right?
Yeah,
so
yeah.
In our teaching, we do offer those positive ways to battle those. And the common thing that we get is, I got fat, I'm always hungry.
Yeah.
So there are some ways that you can help, like not get to help that craving.
Yeah.
And sometimes it works. I mean, again, it's all in your mind.